Hi everyone. I am talking about current porcelain systems. Which one should I choose? My name is Wahab Shakir. I'm a principal dentist. I have a practice in central London Museum Dental Suites. I've had it for a couple of years. And I'm mainly, we're only private work, so we do private work, so we use a lot of different types of porcelain systems. Just to tell you a bit about myself, otherwise, I teach on the Tipton training courses. I have done since about 2015, maybe 2016. I did the courses in sort of 2013, 2014, and I went through the whole system with them. I did the certificate with Bard, I did the diploma with Bard, and then at the time I carried on to do the MCLIN Dent for restorative and cosmetic dentistry, and through at the time it was the City of London Dental Hospital and BPE. So through Tipton training and Professor Tipton, really, I got a lot of really, there were great courses. It's been great teaching on them, and I got the extra training at the end of it and got that all sorted, which was really lovely. We are, I teach, we've been doing no face-to-face over the lockdown, but we're back on with teaching on the restorative course starting in September, really. So that's just the beginning of it. So with this, with what I'm talking about today, the moment someone is to talk about ceramics, what crown do you use, what system do you use, what type of material do you use? A lot of times when I first started, just the names would just come out, and it really was hard to know what to choose and what to do, and also how to talk to laboratories and how to talk to patients and price these things. So I'm going to try and make this as succinct as possible, especially with materials, because when we're looking at different types of materials and what to choose ceramic-wise, it's always, there's a whole world that we could talk about with them. I could talk about just zirconia for the whole lecture, but I'm trying to do all of them, so I'll get through and do what ceramics are out there. That's number one. I'll be looking at just the background to each one. I will be talking about, substructures and things like that, but also just so you know what the important parts of each ceramic and which material does what, basically. Looking at the strength and weakness, well, it'll be some clinical data, some flexural strengths, because hardness strength, just so you know how strong these things are, and just so you get to know them a bit more. And the clinical data of it. I'll show you some examples as well of some of my work and other people's works, just so you know what the differences are between them and what they look like. Which is what we're going to do. We discuss, at the end, I'll try and go through things which I found important when I was learning, which is what to say to the lab, important things about laboratory communication, how to make good choices. You don't want to give your patients, I could make you 5 different types of crowns. You can have zirconia, you can have zirconia monoblock, you can have bonded zirconia, I just wanted to say, it's good to have a little, make a choice of 2, basically, and give those as options. And sometimes the most expensive crown isn't the best crown in the situation, and vice versa. And also how to price them in practice, just how I do it. Everyone's got their own little way, but it's just so you know. Okay. The list that we're going to talk about is on this little circular diagram, which I thought it looked nicer than a list. I took a lot of time on this one, probably too much time, but anyway. PFM, so porcelain fused to metal. Yes, it's not full ceramic, but it's good to talk about it because, it's been there, it's tried and tested, it's long-term studies on it show good survival rates. So it's always there in the background, and I try to compare things to them. Incidentally, a lot of this is from what I learned on my MCLIN Dent, because there was a lot of material science on it, and my dissertation was actually on composite and fibers and ceramics as well. So a lot of this comes from that. The next one's feldspathic porcelain, which is the old school, ceramic bonded crown, which is also tried and tested, been around for a long time, maybe less used now, but worth talking about. Then I've tried to do it sort of time-wise as well, so that it makes sense. Lucite porcelain, which was I've called the Empress One. Then along came lithium disilicate porcelain, which is Empress 2 and Emax now, which we all know very well. Then we go on to zirconias. So either zirconia bonded to porcelain or zirconia as a monoblock, which, you know, zirconia is an extremely strong crown and material, but also quite hard to use, and also lab technique is very important from them. So it's important to know a little bit more about them. The last three, which is resin infiltrated glass, zirconia reinforced lithium dioxide, and nanoceramics, are sort of, they've just come out. Well, that's not entirely true. They're newer ceramics and lesser used ceramics. And I think that it's worth looking at them because it could be the future, because there's some good things about those, some disadvantages and advantages, but very little clinical data on them so far, but it's worth talking about. So starting on PFMs, longest term prognosis, because it's been around for the longest, you know, 40, 30 years, a long time. It's divided into, I'll divide it into what metal is made of and what the ceramics is made of. So the metal part, you either get the non-precious or you get the precious. The non-precious metals are less than 25% noble metals, and precious are over 25% noble metals, including gold and silver and platinum. The ceramic that is then bonded to the surface of them is, well, basically the metal layer is oxidized, so it's more bondable, and it's bonded either to feldspathic porcelain or lucite ceramic. So it's basically bonded to a glassy, slightly lesser filled type ceramic. On top, obviously, you'll need an opaque layer on top of there, and then the ceramic on top. Okay. This is my dear mother. That's my mum. She came in. The 6 was pretty much horizontally fractured. This was quite a few years ago. And quite a few years when I hadn't yet trusted zirconia as much. So I just, it's my mum, what am I going to make? It was a PFM crown, metal margin all the way around, because I wanted to be really minimal on the prep. I also did that inlay at the back, which this was before my Tifton training days, where I would have overlaid that cusp there and probably overlaid that cusp there. But I just was being preservative of my mum, and unfortunately that cusp broke about 5 years later to replace it. But anyway, so yeah, that's what it looks like. It looks good, you know. It doesn't look bad. I mean, yes, metal's there. It does look a little bit opaque, because that's the opaque layer underneath. But again, I just was thinking, what could I give my mum that I don't have to think about or worry about again? So that is where it is there. Next patient, this is a long-term patient of mine. He is a within the space of 3 years, he had a salivary tumor, and he had a aneurysm, a brain aneurysm as well. So, I mean, his teeth are long-term problems with dry mouth. As you can see, the tongue even looks dry there. But before and after, I actually made it at the time. I made these from PFMs. I wanted something where I didn't really want to prep the back too much, because that was good enamel. I just wanted to prep as little as possible. And to be honest, people think that PFM crown preps are quite destructive, but you can be quite preservative with them. And I think there was a bridge here that is a pontic, so it's a combination of crowns and a fixed bridge. So yeah, that was the start off of the issues, and I just really liked I thought that they looked as good as I could for a man in, you know, he was in his mid to late 70s there. So I wanted something that would last, that I didn't think of at the time, didn't have to think of anymore, that would just keep going. So depending on the type of core that you use, it has an effect on the characteristics. So if you want something with a better yield strength, better modulus of elasticity, something that is harder as a material, non-precious cores are good. So if you want to do something which is a bridge, if you want to do something which is posterior on the 7, something that's going to get a little bit more pressure on it. If you want something like well, I mean, it's for post, but it's especially important for post. But if you're making something which is which has a post with not a lot of tooth on it, always look for the non-precious, because it has a better strength to it. The precious cores are lower level strengths, but they can be produced. It's a bit easy for laboratories to make them, from what I understand in the past, but most laboratories now don't mind, they'll do either one of them and they're fine with it. But the good thing about this is thin section, so you can be a little bit more preservative and might be a bit more useful aesthetic work in the anterior section in the past. I mean, obviously now there's other options, but that's what is there. And also, it's good to remember that you can use ceramic margins luckily to reduce the prep depth in non-visible areas with a metal margin. So you put the metal margin somewhere that's not seen, ceramic cutback margin somewhere that is seen as well. So it's a bit better in terms of that. Preps. So labial surface 1.2 to 1.5. You can get these palatal, mesial, and distal zones that aren't visible to 0.5, which is quite preservative, and 1.5 to 2 millimeters on the occlusal. It's quite preservative when carried out properly. It's one of the main things that we teach on the tip and training phantom head courses is just PFM preps, because they are very good preps and they can be very useful on teeth. The main disadvantage as well, the main problem with PFMs is aesthetics really, and also the main problems are because the core is made of metal, it blocks some of the light passing through, well, all the light passing through the tooth because it's metal, so you can get quite dark roots around it, and it's one of the main reasons for replacing them is because you see these margins around them and they look quite dark, and also because of the opaque layers that you have to use to block out the metal underneath the PFM, they can look quite opaque. Okay, so that's PFM press. Next is feldspathic porcelain. So again, not as much used now, but it's there because these are the materials that are available. They are predominantly, they're made of glass with little filler in them. It's where, you know, if you ever went to a lab and saw them mixing up ceramic and slurry and water, build it up and they fire it in the oven, that's how they make it. They just make it like the usual ceramic. The good thing about these is they have excellent aesthetic features. They can look really beautiful, but they're weaker. So you have to be careful where you choose to put them. You know, keep them to low occlusal load, try to keep it for interior work if you're going to use it. Again, nowadays we'll probably be moving towards more Emax, we'll be probably moving towards other types of materials, but these are the things that were there for a long time and worked very nicely, and it's worth knowing about them because if you want to do an ultra thin prep, say on somewhere with an anterior open bite, you could think about feldspathic. You know, they could work quite nicely in that kind of situation. But they're easy to fracture, so you've got to be careful with them. And they've got from what studies showed, they ranged 10 years all the way to 80 to 95%. Many causes of failure is mainly fracture. Also, they are quite rough, and they can wear down the antagonist teeth quite a lot. And they need, prep-wise, they need 0.3 to 0.5 in the marginal area and maybe up to about 0.7 up to the incisal. And they need about 2 millimeters of incisal reduction. The more reduction you do, the better kind of aesthetics you can get from them within reason, obviously. So the main things to talk about: lucite porcelain, lithium disilicate porcelain, they're particle-filled porcelains, and I'm going to deal with them together because they are the two types of the first type, which is lucite ceramics. I'll explain it in the next slide. We don't use them as much because we were using them for a long time, but ever since Emax came along, basically Emax took over the market a little bit. But lucite ceramics I used when I first started using Cerex. They were the first ones to come out, but pretty much soon after lithium disilicate came out, which is Iberclad Empress 2, followed by, well, it was Emax, and Emax is the thing regularly used by dentists. There are other systems that aren't Emax. I mean, last I pressed by GC, but I mean, mainly any lab I talk to when I ask about any lithium disilicates, it's Emax. So, you know, most of them are working on that. Emax is a whole world of a system. I mean, there's they basically cover the whole ceramic market pretty much. And at the end, I've got the list or a diagram of what materials they do. And I think at the end of what we've been discussing, you'll know which one's which a little bit, and we can just make sure that you know what you're doing with them, I guess, in time. Just some clinical examples. This is a Maryland bridge on the upper R2, and I wasn't really sure what would happen to these anterior teeth. It was a friend of a friend. There was a composite and 2 fractured porcelains. I replaced the bridge here and placed 3 Emax veneers, but they were cores of Emax, and they were bonded to ceramic above. So a ceramic veneer layer was placed on top of it. So just to give it a bit of a better look to it. And it was quite close after bonding here. So to be honest, I haven't seen her for such a long time, this patient for a long time. She hasn't come back in for a while. And so I never managed to get a picture from, you know, a few years after, but that's just an example. 2 anterior, well, this is monolithic. So the one before was a Emax core stacked and bonded to a veneer of ceramic on top of it. This is just monolithic cores with staining on top. And again, with this patient, the main difficulty was the different widths. I actually had to add a little bit of additional composite to the upper right lateral there, just to get them a similar width and size, because the teeth were quite wide. Even before this, they were even wider than this. So, so there's the monolithics. And this is posterior. So this is, I use this case as part of the, my ankle dent as well. Where a bruxer, a big bruxer posteriorly. This is just an example of what I did for the lowers. It's a combination of ceramics onlays. Basically, I tried to keep as much tooth structure as possible, kept as much as I could within enamel, within the preps. So I did what more like tabletop preps on those, and then composites anteriors to build up. Same with her upper teeth. I just wanted to show you a good example of what it is. There wasn't a lot of characterization on these because she wears her teeth completely flat. So I, again, this goes on to the laboratory chats. What you sell to the technician, I wanted to keep them quite horizontal because otherwise she'll just chip and break them just like she did those fillings over the years. So next up, anterior teeth. I was ready to make this out of zirconia, to be honest. When I told the laboratory, I said, you know, this is the before here. I actually did some polishing in it just to reshape them slightly so that we get a good wax up made. But yeah, these were alumina actually before. Crowns, very opaque. Patient wasn't happy with them. I took them off. Big metal post there. I was expecting zirconia, but the lab technician said, let's try the Emax. Came out very well. I mean, there's a very slight difference, but not enough for the patient to notice. This was a little while after she had a little bit of gingival problem there, which I hadn't seen that patient for a little while. But when she's back, I want to have a look and see how I can put that, maybe just a bit of extra cement or something like that. But just shows you the idea of what they look like, okay? So then looking at lithium disilicate, well, the ceramics are in 2 types, Emax Press, Emax CAD. So the pressed ceramics are the ones that are produced using a sort of lost wax technique, and the ceramic is pressed into them. The CAD is obviously milled out of blocks as you would in a steric system or any type of milling system. They are made of small interlocking crystals, which are 2 to 3 micrometers in length, and they're interlocking within a matrix. So that's what gives it the strength, is that interlock of the little crystals. As I said, the Emax press is waxed up and pressed and at 920 degrees for 15 minutes. So it's built up beautifully in wax, and then it's pretty much like you're looking at metal, a lost wax technique, and that's how they're made and polished up and stained following that. The idea of CAD is that they're designed digitally and milled out. I think it's just like you would on any 3D system that you guys use, or the laboratory uses usually. Emax is bondable, needs to be obviously treated with hydrofluoric acid and silanated for the best bond strength. And it's better used bonded. This is a bondable material, which gives it good advantages in terms of aesthetics as well, because you can choose different cements and colors and shades, and also when it's bonded, it works at its best. Just that's there's a slight difference between pressed Emacs and Emacs CAD, which is Emacs Press is stronger. It's made of longer grain crystals compared to Emacs, which is finer. So it just means that the flexural strength is better for press than it is for CAD, which means that the force you need to break it basically is better by 40 megapascals. And the fracture point of Emacs, so again, the fracture point is Emacs Press is better than CAD, and they are slightly better. I actually prefer to use Press because I find that the lab technicians can really prep it to a good position. You know, prep it over the margins, and it just gives it a really good sort of final look to it. Oh, hello, I can see that. The next thing is just survival rates. They've got excellent survival rates, over 95% for 5 or even 10 years studies in literature reviews. So they are good. It's a good material. And it needs 1 to 1.2 margins, 1.5 occlusal clearance to 2 millimeters. And it can go down to a minimum of 1 millimeter occlusally. I'd try to keep a bit thicker than that, but it is possible to get it that low. Don't forget that also Emacs or lithium disilicate can be used as a core material, so it can be milled out into a core material with glass porcelain put on top of it. That porcelain, the porcelain that is used for any ceramic system made by Emacs is called Emacs ceramic. So say if you have a zirconia core, if you have an Emacs core, you can use IPS on top of it. That's what the technician would use to build up. There is a slightly different one for zirconia, but we'll go through that later on, okay? So glazing isn't enough to keep this from wearing the antagonist. It needs good polishing. I actually find with my patients, I try every couple of years really just to go over it, just to polish it as much as possible. So just keep an eye on your Emacs cards because you want it to be as polished as possible because you don't want to wear the antagonist teeth. And it's, as it says here, the glaze layer is worn down through quite easily, so you need to gently polish the grounds over time and over its use as well. Just a couple of things to show you, and it's the polishing part here. So here is the Emacs polished with just the red grit diamond and under an SEM. So it's quite rough. It's probably not enough. Whilst here is, and these are made. This level of polishing of Emacs is done with a burr set, a ceramic polishing burr set, which can even be done intraorally. And so it is possible to get them really nice and smooth, just to get a good ceramic polishing kit. Probably an high speed with a bit of water coolant is good, although high speed water coolant COVID is probably not the easiest thing to do right now with AEGs and with AGPs, sorry. But it's just so. Right. And then here is what I was talking about, the surface of lithium disilicate. It's just long crystalline structures all interlocking, which is what gives it its strength. So that was lithium disilicate. I'm sure there'll be a few questions on Emacs and things like that as time goes on, but that's as best as I could sort of give you a rounded look at what it is, okay? And next to look at is zirconia. So zirconia is for a while the new magic material, you know. It's a crystalline ceramic, so it's not a glassy ceramic. It's actually got, you can imagine it as a almost like a white metal is basically what they're discussed as. It started as alumina. And alumina was very good. I mean, I started when they came out. I started with a few alumina crowns, and then I found they fractured. So quite a few studies were showing fracture rates at about 7 to 10 years of them, and they had good flexural strength, but there was just something that wasn't quite right with that material. So really, I don't know of any labs or any dentists I know that use that anymore. But that was the beginning of the sort of metallized ceramics, as it were. So zirconium. It's called yttrium-stabilized zirconium. So zirconium is combined with yttrium. The reason for that is if you just produce zirconium material and heat it up and cool it down, it'll crack. And you need the yttrium there to toughen the areas around cracks. So it actually physically, wherever a crack begins to form, whilst zirconia is being made, it actually strengthens around that, and it's called transformation toughening. So that's how it works, and that's why you need the combination of the two. It can be milled just like Emax can. Going back to it, you can mill your Emax into a blue state first, and then adjust it, check it, and then sinter it. Same with zirconium. It can be milled into a softer green state just because it's a bit easier to adjust once it's fully formed and fully fired. It's quite difficult to adjust those things, as you probably know when you try to adjust a zirconium monoblock crown, sparks fly off, and so you can see how careful you have to be with it. Just a small note: it's just from a laboratory perspective and from a clinical perspective. If you have to adjust a zirconia crown, don't go for it with one of those green or blue or black coarse. Use a high speed, lots of water. Red is not the red stripe is normally good burr-wise to do it. No pressure on it, it's very gently. So it again is produced as a monoblock, or it can be monolithic zirconia crown. That's the word that you'd use. Or as a core, again, layered with ceramic on top. And again, if it was an Emax zircon material, it would be layered with Emax ceramic, or there's another type which is called Zirpress, which is a pressed ceramic that goes on top of it through a lost wax technique. Again, I think most labs that I work with use the Emax ceramic. Zirpress is there as an option as well because it's got a slightly higher strength to it. So monoblocks and core zirconia are different in structure and need to be produced differently. Again, that is something I want to keep to saying that, because if I start to go into the production of zirconia, we'd be here hours. So anyway, zirconia monoblocks need to be polished to a high level. So again, they need to be polished really well because there is a high risk of them wearing antagonist teeth. And so really, I always try to get that occlusal, the occlusion of these crowns right straight off as much as possible. It's difficult to do, and sometimes I have to send these things back. I'd rather they're polished as well as they can by the technician right from the beginning if possible, okay? And just some examples. Patient RTA, front two teeth knocked out, teeth were extracted, implants placed. In that time, he also had Invisalign to straighten his lower teeth, a bit of whitening just to bring them up. And then zirconia bonded to ceramic crowns. It was an FPD I joined together. The main reason I joined them together is because there was we wanted to be safe in the positioning of the implant. The implantologist, when he placed the implants quite high, because he was trying to avoid grafting for this patient because he had quite a thin bone structure, and we were worried about the future, which is quite young, of any of that graft kind of needing to be replaced in time. So we needed pink porcelain. And because he had pink porcelain, it would look very strange to have a divide on that pink porcelain in the middle, so we could connect them together. So that was it. It was, a nice lab did this. They put a bit of mottling, and I was really pleased with the result there. Here, this is the case from Paul Tipton, because to be honest, I haven't done many anterior monoblock cases for zirconia, and I just wanted an example just to show you. My monoblock cases are mainly, single posteriors so far, just because I haven't. How can I describe it? I've only really just started getting into trusting zirconia because I was stung a couple of times when I first started using them because of veneer fractures, and now the monolithics are out, I'm really liking them, getting excellent results from them. But this is obviously a full mouth case, and it's stained up. That is a monoblock. There's no ceramic on top of it, and I think it looks really good. Really nice natural result. Bit of translucency there. It's not fully opaque, so it's a good job there. Now, the main problems is that a lot of the studies talk about the chipping rate of zirconia and their veneering ceramic on top, and it's conflicted. Some studies say that there's quite a high rate of veneer chipping, some say it's a very low rate. They all say that one of the main reasons for post-operative problems is chipping of the ceramic on top. It is a problem, and so I would say maybe try keeping more to anterior areas with lower occlusal forces, and try to look into these monoblocks now, because they're coming out with some very nice, more translucent type of monoblocks for zirconia, so it is a possibility. All right. So zirconia bonded to ceramic needs quite a big prep. You know, they need a good 2 millimeters off the incisal and a good 1.5 millimeters off the margins. And with monoblocks, you can actually be a lot more preservative. I'd still say at least 1.5 millimeters off the incisal, but you can get a 0.5 margin with zirconia monoblocks now, which is really, really useful. As I said, the zirconia cores and substructures that can be veneered with Emax ceramic and Zircus, both cast ceramics. And so it is possible to do it, but as I said, careful on the occlusion, just be really careful on that. It's not a really bondable surface. I mean, you can use aluminium oxide to use on the surface with a sandblaster, and that can help to just make it a bit rougher. But I would say think of it more as a non-bondable surface, so you need good retention and resistant forming impacts when you're using zirconia especially, okay? The monoblock is very promising due to its strength, and because of that toughening system preventing cracks forming, I think it's a good thing to have. I think someone has raised their hand. To the person who raised their hand, if you could write the question in here, I'll go through with it at the end, okay? And I know that there's a few, we'll go on to the questions at the end, okay? But whoever raised their hand, please, at the end, just put in a little, go up to the top and just put in a little question, if that's okay. And we'll answer at the end. So, it's one of the problems with it is opacity. So it's a naturally opaque material. It needs to be stained and covered. With ceramics, the normal way that you get translucency is by getting the grain size bigger, whilst with zirconia, you have to use a different shape of crystal, a different size of crystal, and there's a very specific level that works with them. So from what I can tell you, there it's a complex material, and the science is developing, but they are getting good translucency from it. If you're looking for a higher translucency monoblock to use anteriorly, and these are two systems, Lava Plus and the zircons and the Preto anterior, it can give some good results for, there's quite a few now of high translucency anterior monoblocks to be used. They need to be stained and then fired. That's how these monoblocks are used, okay? So I just wanted to show you now just the Emax family, all right? So there, as we were discussing, there's Emax Press, which is a lithium disilicate, and it's waxed up and invested and replaced. That with the ceramics that's pressed into the lost wax. And then there's Emax CAD, which is milled, and then you have IPS Emax Zircon, which is milled zirconia. And on top of that milled zirconia is where you put, and with all of these, you can actually place the Emax serum on top, and that's the glass ceramic that's placed over the cores. This Zirpress is a material which can be used even for what they're saying for veneers, but it is a glass ceramic that is pressed onto zirconia. That is the whole point of that system. So it's not, usually I think most labs would use the Emax ceramic. And then this is the Empress system, which they use more for aesthetic veneers, and just so you know what the family does. Okay, so when people talk about Emax, that's the world of Emax there, okay? The last thing is to talk about new materials, which is polymer infiltrated ceramics. So this is a lucite zirconia material mixed, infiltrated with resin. So it's basically got the world of resin and composite and the world of ceramics sort of mixed together. So it's got a low level of hardness and elastic modulus, so it fractures quite easily, but it's similar in fracture strength to enamel. And it can be bonded, and once it's bonded, it could be a good option for the future because it is got it's not just a resin material that you can use as an onlay. It's actually ceramic and resin, so it's got a bit more strength and it can be repairable if needs to be. Right now, it doesn't. Apparently, from what I was researching on it, the diffraction of the light isn't so good. So it's better for back teeth. And actually, from what I'm seeing in research, is it's used for implants, because implants are unyielding. You know, implants obviously don't move, and there's no motion in them. Whilst this could give a little bit of bounce, almost a little bit of help for these unyielding implants, so that it's a bit less pressure on them. So that's one of the bits of research coming out about it. And the example name of it is called Inamic, for one, if you want to look for it. Zirconium reinforced lithium silicate. So this is zirconium, it is zirconia, but they're trying to improve on the polishability and how it looks by reinforcing it with lithium silicate. The types that are there are called Celtra, Geo, and Suprinity. It uses ceramic with a much smaller grain size, and the advantage of it over zirconia itself, it's easier to mill, faster to mill, and has good levels of aesthetics, and is easily polished in comparison to Emax and zirconia. Apparently it's easy to polish. I mean, for people that use this is where this ceramic system seems to be working towards at the moment. Okay, and nanoceramics. So these are tiny nano-sized silica particles mixed with zirconia particles. Okay, in a matrix. Main advantage over this is polishability. Apparently, because of the nano sizes of the particles in there, it retains its luster and polish for long periods of time. So it again is quite good in terms that it has good advantage of zirconia plus polishability, which is always a worry with zirconia. Okay, it's an example of that is Lava Ultimate. This is just comparing properties. Main things to see here are the sheer strength, flexural strength, and Vickers hardness strength of zirconium. You can see it's 1,000 MPa in comparison to other materials. It just blows them out of the water. And some people may say it's a bit too strong, but you have to remember that this is not bonded to the tooth. This is actually a crown which is cemented into place, so it's not a bonded restoration. And whilst the other materials need to be a bit closer to the strength of enamel and dentine, because they're bonded to them, they will flex at similar times. Okay, so there we have it. Lithium disilicate Emax here is a good mid-zone. It's got good flexural strength. It's got good Vickers hardness, and that's the one that most dentists are using nowadays anyway. So. Just some examples of zirconia. This was a case which puts together quite a lot of things, actually. There's Emax on there, there's composite on there, and there's zirconia bridge. So this here is a zirconia bridge to replace that missing tooth. And these, the central, the lateral, and the canine is built up with composite because the patient had a lot of wear in her palatal tissues. And then here on the 4 and 5 2 Emax on this. Okay. Again, the lower teeth were built up in composite. And there were plans to replace some of the posteriors after with implants. But the main thing is this patient was in her mid-70s and she needed something really drastic to her teeth, so that's why we did these cases. And zirconia here, quite well layered on top. It doesn't look too opaque at all. Came out quite nice. I was very happy with that result. On the left side again. Composite on these teeth here. As you can see, they're built up in composite, just incisally, and you'll see here why. And this patient, her favorite thing to do was to eat lemons, and I think that the acidity of that, so, that was the main problem, is that she'd worn down these teeth quite severely, and there didn't seem to be any sign of any acid reflux with this patient. I think it was purely dietary. Yeah, on this side again. Onlay. This was a while after she had some problems with her gingiva. She had a lichenoid infection in her gums, which we sent her off for oral medicine to be looked at. But that's the basics there. And just the last 3 slides. The first thing is lab considerations. With labs, it's especially when you're looking at different types of ceramics, a lot of times you're guided by them, but also just realize it's never going to be a perfect match with the lab. You need to always talk, always have conversations. Try to find someone who you like, you know, has a passion for it and is willing to work to do things like, so if things go a bit pear-shaped or things aren't quite working, is ready to talk about it, is happy to. And don't just, you know, if one tooth doesn't work, don't just drop them straight away. Try and call them, talk it over, see if it works out. Write long lab notes like, you know, please turn over, you know, press to the margin, make sure your Emacs is nice and tight on the margin. Always ask them, you know, tight interproximal contacts. Tell them what kind of chamfer you want, the thickness of your emergent profile, and what kind of cusp angles you want, staining, aesthetics, you know, draw diagrams for them. They love it. You know, I honestly think that if the lab technician gets more information on how to make the ceramics look good, even on a molar, I think it's just nice to go for, you know, a good amount of aesthetic beauty, even on your posterior teeth ceramics, anteriors especially, okay? And lastly, the most important thing, I guess, for a lab technician is, you know, margins, prep, quality, smoothness. So if you feel like you're not prepping as well as you could, it's always, you know, always think about maybe it's time to go on a bit of postgraduate training, a bit of practice, you know, just always makes perfect, okay? And especially on the Tipton training courses, it's a prepping course, you know, especially when you go on the Phantom Head course. It's just every time you're in, we prep and prep again until we're getting things a little bit more stable in how you're prepping, okay? Ethical choices, I think, trying to give a patient 2 or 3 choices, you know, try to work out, okay, so this tooth is as I was showing you on those pictures, you know, it's an anterior tooth, it's aesthetic, there's a dark core in it. Maybe you're looking towards more zirconia. It's a posterior tooth, bruxer. It's with, you know, it's a single tooth restoration. Maybe think of a zirconia monoball. If you're trying to be as aesthetic as possible, then yeah, you're looking at stacked ceramic, something with either an Emacs core or going on to feldspathic. So I hope that what I've been talking about today gives you more of a rounded view of what options there are and what your judgment would say when you're looking at things, especially its aesthetics and function. Really, that's the 2 things that you're looking at. And it's okay, well, if you're not happy to offer a treatment that you're not comfortable with, if you're not comfortable with a certain type of crown, it's okay not to you know, give that option to the patient. Choose what you're comfortable with, but if you want to move on to more high-end or aesthetic types of treatments, then it's worth learning it, okay? And also, when you're looking at your ceramics, the most likely reason for them to chip and fail is normally occlusal issues. You've got to also be really careful with your occlusion, how you plan things, pre-plan your occlusion, and make sure that there's enough space for what you're doing. And so it makes your choices worthwhile, because sometimes you don't want to make a choice and then it fails on the patient. So you want to make sure you're doing the best you can. And so, as I said, it's a balance of clinical judgment, which is aesthetics over occlusal restorative issues. So aesthetics would tipping towards aesthetics and more sort of aesthetic systems such as Emacs and layer composites would be, it's an anterior tooth, the patient has a high lip line, has a high aesthetic demand. And then on the other side is occlusal issues, which is lesser aesthetic demand. So, you know, back tooth, upper 7, something that's not so seen. Also high occlusal pressure, so someone who's a bruxer. It's a posterior tooth as well that you're worried they've cracked roots before and broken teeth before, so you want something strong. And also obviously bruxism in worn teeth and signs of DMD as well, or bruxism. You just want to be sure that you're using the right thing. For some patients, I still sometimes make DFM crowns because I think this patient's a serious bruxer. I'm going to make that because I think that's going to be the strongest thing. But if it's a patient with a high lip line or wide smile, you're doing a 6. Sometimes you have to do that in Emacs if you want to get it right. But nowadays, I'm using a lot more zirconia monoblocks for posteriors, even 4s and 5s. They're coming up looking very nice indeed. And I'm quite happy with the strength of them. I've not had any problems with them really. And if you find a good lab who knows what they're doing with zirconia, you can get some lovely results. Okay. Pricing, as I said, I mean, when you're first starting, some people are a bit shy about it. They don't want to, they feel like they shouldn't be charging the prices that they should. But at the end of the day, you're doing a good service for someone and they're paying for it. And I think that you need to charge it accordingly to help run your life and your business. Otherwise, it's not going to work in the long term. And obviously, if some people feel they need to train for further to be able to attain and charge those higher prices, and that's absolutely fine. You know, go on as many postgrad programs as you can. Lab bills can vary. I mean, they can go anywhere from £80 up to £450 per crown. So you have to know what your lab bills are before you start. Add an hourly rate on there, and that gets you roughly to what you need to charge. Also, it's very important to look at your local practices and competition to know what they're charging as well. So you know. Single teeth crown, anterior tooth will always cost you more because you may need further visits, you may need further try-ins. So it's really important to charge accordingly for that. You know, have a separate cost for a single tooth crown. You've got to, because it takes so much more of your time, and so a lot of times the lab bills are higher as well. So I feel like I sped through that to get through that within the hour, but I hope I've covered as much of ceramic systems as I can, what was available, what is available, and what is becoming available. And thank you. I think we've got some questions that are left behind from some of the patients, and I can go through with them as well. So let me have a look. I hope you enjoyed that. There's a question from TH. If placing an Emax onlay upper premolar after endodontic treatment, what is the best way to hide a margin, blend it for aesthetics, and also preserve tooth structures? Emax onlay upper premolar after endodontic treatment. Okay, so if it was a non-endodontically treated tooth, I would most of the time finish super gingerly. I'd be happy with it, because once you bond that ceramic into place, whilst you're banging it in, it may not look great. You might see that line between your ceramic and between tooth. But actually, once it's bonded, it looks absolutely fine. Like that case that I showed you before, where it blended in quite nicely. Let me try and find it for a second. This. Yeah, I mean, that is an Emax onlay there on that tooth. This tooth wasn't root filled. I believe that tooth was root filled from memory. But you can see that the line pretty much disappears. So, but with root filled, worried about, so with root filled teeth, if you're concerned about buckling underneath, that's a conversation you've got to have with the patient. I think a lot of times I would take it up to just below the gingival level, sort of 0.5 above. I think that it's good to try and hide those margins. But if you're trying to be preservative, say to them, this is what I'm going to do. It will last you well, but there's a chance that the tooth's going to go grey. And if it does, you're going to see that margin. Some people are actually fine with it. Some people prefer the preserving those structures quite a lot. So it would be a question that you have to discuss with the patient and make sure you're doing the right thing for them and they know what the results might be. Okay. And what is the best material for a 3 to 5 unit posterior bridge? Honestly, I'm still using PFMs. Because you can use fixed movable joints in them, but I think zirconia is the future for that. I mean, recently I cemented a case for an upper implant case going from the upper right. Well, it was basically pretty much a full clearance on top, and that was zirconia bonded to ceramic. It did chip though. I have to say that there was a little chip in there, but I am starting to press zirconia more and more for long unit bridges, but I'm still on PFMs, to be honest. Another one, hi, I've had 2 cases in 2 years of placing lower right 6-7 zirconia crowns simultaneously, having 7 crown fracture. One of those cases was today. That's the worst. I mean, what I would ask you, that's Gavin who asked that, was it a monoblock? Was it bonded to ceramic is the question that I would have on that one, because if it were bonded, that's probably the reason why. Other reasons are, if you're adjusting it on fitting, sometimes that will put some weaknesses in it. So remember, use that red high speed to adjust If you're not sure with ceramics, send it back, let the laboratory technician adjust it. But just that is one of the main reasons for fracture. It's a nightmare when it happens, but yeah, I think keep plugging with it. Have a chat with your technician. Maybe there's something to pick it up with, but it may have been because it was wasn't a monoblock, and that's why. On an anterior high occlusal stress case, is it possible to have a zirconia fused to porcelain on the buckle and just zirconia on the palatal deep bite? Like metal, yes, I cannot, well, actually that's not entirely true. You need the zirconia covered with something because they're slightly different materials, but that is something that is occurring now. I think that we're getting to a point where you can do that, where you leave the palatal and zirconia and buckle and porcelain just as metal is. Non-bonded monoblock. So the from what I understand, that crown which broke was a non-bonded monoblock. Yeah, Gavin, that was really unlucky. I think you have to have a chat with your lab and just make sure that they know it's happening. Maybe it's something going on with your lab technician. Just make sure you have an open conversation. Say it's happened twice. You know what's going on. Was there enough space there? If there was enough space and everything was good, there must be something in the material that they're choosing or using. What is the best luting cement for zirconia and Emax crowns respectively? Zirconia, I would use a Fuji Plus. I would use something, I mean, you can use a resin. It's possible with zirconia, if you don't have a lot of substructure, you can bond, you can use a bonded, some bonding to cement the zirconia in place. It'll just help a little bit. But mainly with zirconia, I'm using glass armor based, resin modified glass armor based luting cement. For onlays, always resin. If I find, just to be careful with post-operative sensitivity, the rule I try to use is that for a root canal filled tooth, I'd etch the enamel and self-etching and bonding cement, such as I use one by GC actually. And if it was a tooth which was vital and I could get good, if I could get not much saliva on this, if you're rubber damming it and making sure there's nothing on there, I bond it into place, etch bond, and I use NX3 resin cement. Okay, so I think we're just about on the finish time. If anyone obviously has any further questions, I think I've answered through all of them really, so. Thank you for attending.
Oh, thanks, Wahab. Thanks for a great webinar.
Cheers, Louise. Thank you.
Yeah, if anyone's got any other questions, obviously they can email them over to me and I'll direct them in your direction, yeah?
Yeah, that'd be great. Thank you.
Okay, I'll see you in September.
See you then.
All right, bye.
Everyone. Bye.